Hello, everyone. Thank you so much for attending our webinar today on accessing CASGEVY in Canada. We're going to have an interesting discussion today. We know that new medical technologies like stem cell transplant, gene therapy, and gene editing are creating promising treatments for sickle cell disease. However, these treatments come with risk, and doctors still need to study how safe and effective they are in the long run. This session will help explain how these new treatments work, their possible benefits and risk, and how personal factors can affect the decision process. So thank you so much for joining us today. I'm going to go ahead and just start sharing my screen.
Donnell, Dr. Ivy, hold on. A couple of people are saying from the audience that they can't hear anything.
Okay.
Oh, really? But we can hear.
Yeah, we can hear. Bessie can hear.
Yeah.
So it might be on your end if you can just check with your audio system to see if you can remedy.
Maybe to check your audio, you're right.
Yes. So we have a wonderful panel here for you today. And as I said, the title of this program for Learning for Life today is Accessing CASGEVY as a Curative Treatment Therapy in Canada. We will hear from Dr. Kevin Coe, who's a hematologist and has been doing research at the Scarborough Health Network. He's currently the Vice President of Research and Innovation. We also have Lan Ray, who is the president and CEO of the Sickle Cell Awareness Group of Ontario. And we're fortunate enough to have Gabriel, who is a transplant recipient and also a producer director, who we're going to hear about later today as well. Now, our program will include, having welcome and acknowledgements, housekeeping rules, which I'll go over in just a minute. We're going to then hear a panel presentation by Dr. Kevin Coe on the hype and hope for curative therapies for people with sickle cell disease. That would be followed by Gabriel sharing his personal experience with transplant. And then lastly, but definitely not least, we're going to hear from Lan Ray talking about advocacy and access to CASGEVY. We do ask that everyone hold off on questions. If you have questions, please enter them in the chat so that we can address them later. But in order to get through the program, and we do know that there's a lot of interest in this area, we are going to hold off on questions until the end. So logistics, so just to let everyone know that this session, it will be recorded, so it is made available for reference or for attendees who are not able to attend in person and live today. As I just mentioned, if you have any questions as you hear the panelists, please use the Q&A or the chat feature to send your questions to us. And we will go through as many of them as we can get through during the question and answer session after our last panelist. So we will be holding off on questions and answers until all of the presenters have finished their presentation. Now, I do want to give a land acknowledgement. We are grateful for the opportunity to gather, though virtually, on this land, and we thank the generations of indigenous people who have taken care of this land long before other national groups have joined. In particular, we acknowledge the traditional territories of the Ojibwe, the Ashkenazi people, and the Mississaugas of the New Credit, whose territory is covered by the Upper Canada Treaty. We also recognize the contributions the Métis, Inuit, and First Nations and other indigenous people have made in shaping and strengthening the province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoings of the past still impact the present and the future. I encourage everyone at this session to actively seek information and to take action. Now we're going to start our presentation, as I mentioned, with Dr. Kevin Coe giving a presentation on the hype and the hope of curative therapies for people with sickle cell disease. I believe a lot of you know Kevin Coe. And so I'll go ahead and let him start giving his presentation. Just to give you a bit of information about Dr. Coe, Dr. Kevin Coe is the Vice President of Research and Innovation at Scarborough Health Network, an adult hematologist at the Red Blood Cell Disorders Program at University Health Network, associate professor in the Division of Hematology at the University of Toronto, and associate professor at the Institute of Health Policy, Management, and Evaluation at the University of Toronto. His clinical focus is on rare congenital hematological anemias, and his research focus on novel therapies in the hemoglobinopathies and rare anemias, the impact of sickle cell disease on neurocognition, and non-chelating methods to treat and prevent iron overload. Now, I've known Kevin since before I immigrated to Canada. I've had plenty of conversation, and he's actually been my doctor since I arrived in Canada 5 years ago. So with that, I'd like to stop sharing my screen and then turn it over to you, Dr. Coe.
Dr. Ivy, thank you very much for the very generous introduction, and I'm very honored and pleased to be here with you all today. And speaking personally, before I start, I just want to tell everybody I haven't left. Okay, I'm still here. I think there's lots of rumor that I disappeared. I haven't disappeared. I'm around. I'm mainly in Scarborough right now. Not only am I starting research there, but also building the sickle cell clinic there. But I'm also part-time at Toronto General Hospital. I'm going to share my screen. Hopefully everybody can see. It's coming up now. Yep. Thumbs up if you can see. Perfect. Thank you very much. So today I'm going to talk about the hype and hope of curative therapy for people with sickle cell disease. These are my conflict of interest disclosures. If we look at the therapies that are available in Canada, and here I'm comparing between 5 jurisdictions, which includes the United States FDA, Food and Drug Administration, the European Medicines Agency, the UK MHRA, which is the regulatory body for the United Kingdom, the Saudi FDA, as well as Health Canada, we can see here that in Canada, there is a lack of therapies available. Now, many of you are on hydroxyurea, but because hydroxyurea is such an old drug, and when a drug gets approved, it needs to have an application coming from the drug manufacturer. Because hydroxyurea has been around for so long, that there's never been an application, kind of like aspirin, if you think about it, to Health Canada. And this is why, even though we use hydroxyurea across the world for the treatment of sickle cell disease, it is approved for other indications, but not for not for sickle cell disease. CASGEVY or exa-cel, however, is approved and was recently approved, as many of you know, with a lot of fanfare in September of 2024. I'm going to go through some of the things that we still need to do in order to make exa-cel available in Canada. When I say exa-cel, I mean CASGEVY, but in the medical community, we tend to refer to it as exa-cel. But we're going to go through how we can make it accessible. Now, more importantly, is that as you can see in other jurisdictions, like the Saudi FDA, EMA, UK MHRA, these areas as well, is that there is a limited number of options. And while hydroxyurea is approved, as you can see across all the different jurisdictions, you can see here that a number of newer therapies like L-glutamine, voxelotor, and crizolizumab, the regulatory agencies has either refused authorization or that their authorization was recently revoked or withdrawn from the market. Why am I showing you this? because it shows that there is still a lot of work for us to do in finding new ways in treating sickle cell. And we all know that more options, the better. In a devastating disease like sickle cell disease, as many of you know, many of you experience, it is unacceptable to only have, in Canada, one option, but in many other areas in the world, only two options. Whereas if we look at diseases like heart attack or high blood pressure, I mean, just high blood pressure alone, in my brain, I can name off 25 drugs right now that we use. This doesn't even include the combination therapies. How is it that with a disease so devastating that we only have two options? We need more options. That's number one, the point I want to make. But even in the United States, I'm going to flip back to the previous slide, even in the United States where you see most boxes are green, meaning that many of these disease-modifying therapies, and they have two, not one, but two gene therapies available to them, both exa-cel and lovo-cel, that disease-modifying therapy remains underutilized. And this is in the United States, despite them being approved. Only 24% of people are on some sort of disease-modifying therapies. Now, of course, as you know, there are many reasons as to why this is underutilized, but it's important to realize that we need to start using these disease-modifying therapies, because with gene therapies and stem cell transplant, yes, they can be curative, but they're not without cost. And I don't mean financial cost. I mean, you know, the human aspects of cost, right? The risk, and the unknowns that goes along with these treatments. So the backbone of curative therapy right now still rests with stem cell transplant. What is stem cell transplant? Stem cell transplant essentially is that we use a medicine to move the stem cells in the donor, okay? So, and you know, we can talk about the types of donor in the next few slides, but the donor will get the stem cells just like an IV. Instead of infusing the drug, you know, we're actually using an IV to take the stem cells out from the donor, and then that stem cells gets cleaned and then put back into the recipient, the person who's receiving it, the person with sickle cell. Now, there are what we call indications for using stem cell transplant for people with sickle cell. Why is it? That is because there are, again, risks with stem cell transplant. And of course, we need to make sure that the benefit, the potential benefit, and remember, there's no guarantees, right? So the potential benefit that we get from stem cell transplant, it outweighs that of the risk. And so what are some of these indications? This includes having a history of stroke, having chest crises 2 or more times a year, having recurrent pain crises 2 or more times a year, being on regular transfusions, having silent, what we call silent infarct or silent stroke in the brain, osteonecrosis of more than 2 joints, priapism 2 or more times requiring medical attention, proliferative retinopathy, you know, the damage to the eye, pulmonary hypertension, nephropathy, or, you know, the kidney diseases, liver diseases, lung diseases, okay? But in addition to that, we also have to consider compatibility. And the reason why we need to consider compatibility, because right now, as it stands, matched sibling donor, meaning that you getting a stem cell that is matched to you from your brother or sister, is still the best option we have in terms of providing a potentially curative approach. You can see on the bottom right-hand corner here, the survival is pretty good, right? A 1-year survival, 98%, 5-year survival, 93%. The chance of getting a devastating complication called graft versus host disease, where essentially the stem cells that you get infused into you attacks your body, it's relatively low, you can see here, right? But there is still a chance of dying from a stem cell transplant, and that sits around 6% or so. So 6 out of 100 people, right? Or 3 out of 50 still has a potential chance of dying from a stem cell transplant. But despite that, these numbers are still pretty good. And this is why, because of that risk of death, this is why we have a very selected list, agreed upon list across the world. That list is not just in Canada or US or the Europe, that's across the world. We all agree that those are the so-called indications, or those are the reasons why we should go for transplant. In addition to being a match, okay, from your brother or sister, you also need to be what we call ABO blood compatible, meaning your blood group also needs to be compatible. And with that, because of the need to be both ABO blood group compatible as well as what we call HLA compatible, the number of donors, chances that you can have a donor is really limited. I mean, consider yourself like how many siblings you have, right? I'm a single child. But so are many of you, I believe. Some of you, of course, are lucky enough to have siblings, or unlucky, I don't know. I'm sure people have various opinions about that. But you can see here that there's still limitations, right? Like meaning that if you look at the States, or even in Canada, it's around 15 to 18%. That means there's only 1 out of 5 chances that you can actually find a match. In some of the places, it's much higher, but that's just because of there's a high proportion of what we call consanguinity, meaning cousins marrying cousins. So the chances of you finding a match is actually higher in those places. But that's overall in Canada, we're dealing with around 15%. Which means that we need an alternative solution, right? Because you can imagine that even those who are eligible for transplant, they are not necessarily going to get a transplant because they don't have a sibling. And so we have now exa-cel that's been approved. Now, I'm just going to go through what exa-cel is again, what it does. What it does is that it mimics the effects of hydroxyurea. Well, how does it do that? It increases fetal hemoglobin or baby hemoglobin, because you have to remember, right? Every person who's born with the sickle cell gene do not get sickle cell complications until they're at least 4 or 6 months of age. Okay. And the reason for that is because babies, both unborn babies as well as newborn babies, produce a type of hemoglobin called fetal hemoglobin. I like to call it baby hemoglobin. And the baby hemoglobin essentially doesn't have that sickle cell mutation in it. And so what the gene editing does is that it recreates that effect. And the way it recreates that effect is by literally going in there, cutting the cell's genes. And this specifically the type of gene that it cuts is called BCL11A. Once it cuts it, it disrupts it. And when that gene is disrupted, baby hemoglobin is made. Okay. And so it's trying to mimic exactly the same effect. Now, hydroxyurea doesn't cut any genes. It does it in using a sort of what we call pharmacological method, or uses a drug method to do it. But in this case, it uses it with exa-cel, CASGEVY, it uses a genetic method to do that. Now, the journey of a person going through gene therapy rests on the bedrock of a stem cell transplant. It's exactly like a stem cell transplant, except that you're using your own cells as your own donor. So you first have to go through screening, and screening is not a short. It looks short here on this very long infographic here, but stage 1 here, screening, actually is going to take anywhere between 6 months to a year. And the reason is because there's a number of considerations that we have to go through, and we can talk about that. But this includes things like your psychosocial well-being, your finances, right? Are you not your ability to pay? Because in Canada, our expectation is that this therapy will be funded in some form or fashion. what we need to consider, though, is the fact that you're going to be out of a job, right? If you're working, if you're in school, you're going to be out of school. And so, what are some of the implications that goes along with being out of school or being out of a job for a very long time? And we also have to consider things like, are you fit to go through a stem cell transplant? And so there's a number of tests that we need to do in order to see if you qualify. And that can take quite a long time. And once that's done, then your cells are then mobilized or pulled out of your body. And the way we do it is with a medication called plerixafor, okay? Given the nature of sickle cell disease, it's often hard to mobilize the stem cells from people with sickle cell. It takes on average 2 cycles to do this. Sometimes it'll take more, up to 6 cycles. But once we do get the stem cells, we then go through a process. The cells will be shipped to specialized laboratories where the laboratories will first of all create more of your stem cells, grow more, then do what we call editing, like the steps that I've shown you to disrupt that gene, the BCL11A. Once the gene is disrupted, then we can take those cells, freeze it. We're gonna, the labs need to do a final qualification check. Once quality check is done, then the cells are being shipped back. That entire process takes 8 weeks. Now, because it's a very complicated process, there's only a few slots available. So often, what we'll need to do, at least during the clinical trial, is that people need to sort of line up to be wait in line to get to the stage of the manufacturing stage. But once it's created, frozen, then it gets shipped back to your hospital, and then the hospital then needs to be capable. The hospital where you are needs to be capable of doing the stem cell transplant, and not every hospital in Canada are capable of doing a stem cell transplant. They have to be what we call a FACT accredited facility in order to do that, because there's a number of, again, both quality assurance as well as safety assurances that they need to meet and also the capabilities and the expertise, right? And the expertise is not just, doesn't rest with just doctors, right? You have to remember there are nurses, the technicians, the laboratory technologists, the imaging technologist, the physiotherapist, social worker, pharmacist, the stem cell lab, like all of these have to work in concert together to provide that therapy, to provide the stem cell transplant to you. Once these cells are then get back to these FACT accredited facilities, then you need to undergo chemotherapy. And the chemotherapy that we typically use is called busulfan. The reason why we use busulfan is because busulfan is able to wipe out almost all the stem cells in your body. Okay, so we're clearing house, right? Because remember, we want the new cells to come back into you, right? But before we put them back in, if your house is full, if it's occupied, well, we can't move the new tenants in, right? So we need to sort of clear house first, evict the old tenants before moving the new tenants into the house, into your house. Then once we clear the stem cells, the old stem cells with the busulfan, we then will infuse the exa-cel into you. Now, stage 4 takes around, the engraftment stage takes around a month or so. And then, of course, after that, you'll be followed, and so on and so forth. Now, right now, we're set to follow you for life, of course, but a lot of the monitoring and the testing will be for 15 years, and we'll go into why that is the case. Also, throughout all this journey as well, is that when we use chemotherapy, of course, there's a high chance that you'll be rendered infertile. And so we need to make sure that there is fertility preservation in place, as well as in case it fails, and the chance of it failing is extremely low, but in case it does fail, we need to take a backup aliquot of cells. Now, if we look at the studies for people with sickle cell disease, you can notice immediately that the people who the types of sickle cell that were enrolled in the study did not include those with hemoglobin SC disease, and that's a huge gap that we need to address going forward in the future. Nonetheless, in this group of patients in this study, you can see here that 97% of people met the primary endpoint, which is no pain crises for at least 12 consecutive months. And you can see here on the right-hand side as well that there's none of the patients required hospitalization for severe pain crises for at least 12 consecutive months. And you can see it here on the next slide here. This is what we call waterfall plot. The little blue diamonds are essentially number of, essentially a pain crises. And each line here represents a patient. And the length of that line represents how long they were followed. On the left-hand panel here are pain, sorry, I flipped it around. On the right-hand panel here are pain crises. On the left-hand panel here are the hospitalizations due to the pain crises. Okay, and you can see here that in terms of hospitalization, you can see people were hospitalized very frequently, right? This group of patients, but then very soon after receiving exa-cel, that they did not have any hospitalization at all, save for this 1, 2, and 3 persons who only had one hospitalization. And if you look at pain crises as well, remember these are including pain crises that happen at home. You can see here that virtually everybody had no pain crises. Nonetheless, we are actively monitoring everybody who have been on the trial, and the reason why we're doing that is because, as you know, in some gene therapy, not with exa-cel, but in others gene therapy, like lovo-cel, for example, there were 2 persons who developed blood cancers after they received the lovo-cel therapy. And the question, of course, is that, can this happen with the exa-cel as well? The question is, we do not know. There has been a number of studies, but all these studies were done in the lab in Petri dish. So we can't tell whether this is actually going to happen in people with sickle cell. Not only that, we also have to consider the fact that when we talk about gene therapy right now, at least right now, the bedrock of gene therapy is stem cell transplant. And there is a high risk of having cancer after stem cell transplant. Not high, as you can see here, right? A 10-year chance of getting leukemia or MDS, which is another form of blood cancer, is around 1.7%, so just slightly higher than 1 in 100 people. And if you consider any cancer, we're talking about just a little over 2% or 1 out of 50. It's low, but nonetheless, it's not something that we should ignore. Last but not least is that this is all that increased risk is befuddled or confounded by the fact that just having sickle cell alone increases the chance of having cancer, unfortunately. You can see here that in a study in Blood of 2017 that compared with the average Californian population, people with sickle cell disease have a 72% increased risk of having blood cancers. This data is replicated across, in other jurisdictions, like in England, for example, that showed a 3 to 10-fold increase in incidence of blood cancers as well. Now, what are the risk factors that people with sickle cell disease have that could increase the risk of having blood cancers? It includes things like reactive oxygen species that are generated from the sickle cell that gets damaged along the way during the lifetime. Lots of cells are constantly being moved. So the more cell cycle you go through, the higher the chances mistakes can be made by the stem cells in your body. As well as damage to the lining of the blood vessels, to essentially the tissues not having enough oxygen, right? So there are a number of guesses that we have. We still don't understand exactly why, but that is unfortunately the case. So how do we then reduce the risk, right? These risks that we just talked about. The FDA, of course, and Health Canada and other jurisdictions have follow suit. Is that there's a mandated 15-year follow-up. There is active surveillance in anyone who gone through either stem cell therapy or gene therapy to survey for cancer. There's also looking into the blood as well as to the bone marrow to what we call off-targeting editing surveillance, as well as looking at vector copy number for novel cell, if it's a novel cell. So moving on to exa-cel alone, of course, it's great that exa-cel was approved. It was approved on the 23rd of September, 2024. And you can see here that in the official product monograph here, the indications are actually quite plain, which is great because that means that we can potentially apply this therapy very broadly across almost all people with sickle cell. So the indications for exa-cel is for treatment of people with sickle cell 12 years or older with recurrent pain crises. And that is suitable for use in pediatrics, but you have to be at least 12 years of age because CASGEVY was tested in adolescents as well, which is a great thing. The contraindications, of course, is anything where a stem cell transplant or the conditioning is contraindicated. So if you're not suitable for the stem cell transplant itself, you can't go on CASGEVY. And also, of course, allergic to any of the ingredients within exa-cel. Then the question is, if the product monograph is telling us that CASGEVY can be used in almost everybody with sickle cell, then how do we then prioritize a sequence, right? Because ideally what we want to do is treat the people who will benefit the most from the therapy, but B, also has the greatest need. Well, how do we sequence that? The European, both the European Hematology Association and the European Bone Marrow Transplant Group have joined together to create a consensus statement. Okay, so you can see here that it's written by a number of people who have not only done the gene therapy trials, but also are sort of experts in this area. And the recommendations are the following. I'll summarize this to you. So you need to have at least 2 pain crises requiring hospitalization per year in 2 previous years with no response to hydroxycarbamide, which is hydroxyurea, as they call it in Europe, at maximum tolerated dose. So that's key here, right? Either alone in combination of other treatments, or recurrence of acute chest syndrome or chest crises in spite of hydroxyurea at maximum tolerated dose. So what they're saying is that hydroxyurea is still the backbone of treatment with sickle cell disease, and that this therapy should only be considered in people with complications from their sickle cell disease, despite the use of hydroxyurea at maximum tolerated dose. And for these people, they qualify for what they call SCD treatment intensification. And then the next question is, what is the genotype? Remember how we talked about previously that the exa-cel trials, only people with certain sickle cell genotypes are enrolled and that the SCs were excluded, people with hemoglobin SC disease. And so this is it. So unfortunately, right now, SCs are still excluded. And then for those who don't have SC disease, then the next question is, do you have a match family donor, right? You know, a brother or a sister. And if it's a match, then you go for stem cell transplant, which, as we talked about, match stem cell transplant is still the backbone of therapy. But because only 15% of people will have a donor, most people are likely going to go down this no category. And then if you're less than 12, you know, that because exa-cel is not approved for people less than 12 years of age, then this would depend on what's offered at your local center. Like, for example, there are newer clinical trials that are looking at the efficacy of gene therapy at a much lower age than 12 years. But assuming you're 12 years or older, then you then go through the gene therapy in the transplant center. And you have to go through the assessment first. And if the assessment, remember all that 6 months to a year work that we talked about in terms of screening, if the screening looks good, then of course you can go for gene therapy. If not, then you need to look at other options. Now, more importantly, is that and the way they sequenced it were, you know, of course, there are the basic requirements that are already in place for people. In this case, you know, including those, you know, with 12 years of age older, as we talked about, no matched sibling donor, and having 2 crises a year. Now, given this, of course, right, is that we also have to consider other indications as well, because we want to expand the access of this therapy, right? So the group actually considered that as well and listed a number of other indications that people can also benefit from, in addition to those that were outlined by the regulatory agencies. They also outlined, you know, a number of factors in which essentially would put the patient in danger if they were to go through the stem cell transplant, the gene therapy. And that's listed on the right-hand side. Now, this list is actually very similar to stem cell transplant to begin with. But then, of course, in that group, right, they're all experts, doctors, you know, in this area, and patient voice was not included. And so there are now a number of studies out there that also includes patient voice, and here's one of them. And in this particular study, what the group looked at were how would people choose gene therapy versus no gene therapy, given the potential risk and the potential benefits that are involved. So in every scenario that they gave to the participants who are patients, adult patients, or children with their caregivers in place, they asked them the following questions. They included the following factors. What's the chance of having no symptoms of sickle cell disease after treatment, meaning that you're quote unquote cured? What's the expected increase in life years, right, after the treatment? What's the chance of death in 1 year after treatment? What's the increase in lifetime cancer risk after treatments? And they gave basically 3 choices: gene therapy A, gene therapy B, and no gene therapy. No gene therapy always the same in terms of the sort of the baseline. When we say baseline is, you know, you are as you are, which is outlined in table 2 down there. But in terms of the combinations of the benefits and the risk in these 2 choices, gene therapy A and B, what they do is that they just choose a combination, a random combination of benefits and risk. And you can see out on the right-hand side here are the parameters that are put into this discrete choice experiment. So for example, you in one scenario, you can have gene therapy A with 90% chance of no symptoms, but 4 years more increase in life years and 30% chance of death. and unknown cancer risk. Another scenario could be 60% chance of no symptoms after sickle cell treatment, of sickle cell after treatment, but 8 years of increased life years, but has no chance of death, but in not expected increased risk of cancer. So they would have all these combinations, and they would divide, and then they had divided the patient groups into two groups. One is group A with mild symptoms, and group B with moderate symptoms from their sickle cell. And the last question they ask as well is that, and then they changed the scenario to ask the participants to imagine that they were in a worsened state. So for example, if you're in group A where you had no chronic pain in the last 6 months and no pain crisis in the last 12 months, they would ask the participants to imagine if they had chronic pain in the past 6 months and 5 or more hospitalizations in the past 12 months. Okay, let's see what was the result. The results were quite, to me, quite interesting and surprising, in the sense that for the adult participants, that they would require at least a 60% chance of acceptable benefit, meaning that no sickle cell symptoms after the treatment, for them to accept a 10% chance of death. Conversely, if, say, the chance of death was much higher, 30%, then the bar gets even higher, right? For the minimal acceptable benefit, and increases up to 71%. For the parents of the children, however, you can see here that the minimal acceptable benefit chance the threshold was much lower. So instead of the adults needing at least a 67% chance of guaranteeing them that they're not going to have any symptoms, the parents are saying, you know what, I'm okay with just 8% chance of a benefit, almost like any chance of benefit. I'm happy to accept a 10% chance of death in my child. And for the parents, the bar goes a little higher if the chance of death to the child is 30% chance, with a 25%. So this is for the people group A with very mild symptoms. For those with moderate symptoms, though, at baseline with sickle cell disease, you can see here that they would accept a much lower threshold, right? Because they're sicker, they would accept much lower threshold, even with an increased chance of 30% chance of death. And then when they were to imagine that if they were to have worsening symptoms, you can see how also the acceptability gets better, it gets higher, even though there's still a high chance of death. This is only one of the different types of studies out there. What I'm trying to illustrate is that I think patient voice in consideration of treatment options is not just individually, but in terms of formulating a policy, right? Especially in Canada, because right now, currently, we don't have a policy in Canada in terms of prioritizing and sequencing people with sickle cell disease for treatment with exa-cel. And then, of course, we also need to consider the patient journey. We talked about the patient journey previously, right? But we also have to consider the other impacts on family, impacts on the caregivers, impacts on jobs, impact on your psychological well-being, impact on finances, etc. And so this is one sort of roadmap that the Centers for Medicare and Medicaid Services from the US have drawn up, right? Going from learning about gene therapy to talking to hematologists, to the referral center, to comprehensive evaluation, all the way through the collection phase and to the treatment phase in the hospital, to the follow-up for 15 years. And what they have done is that they have made a call out to both the states, the different states within the United States, as well as to the manufacturers of the gene therapy, to see if they're interested in sort of creating a patient journey, a better patient journey to provide grants to them to create a better patient journey experience for the patients. But currently we don't have something similar like this in Canada. in terms of funding availability. Last but not least is we got to consider the types of hurdles that we need to get through, right? How we got Health Canada approval, yay, right? But that's just the very first step in this long journey you can see here. This includes, going through CDA. We just went through CDA and INES, which I'll show you the results. This is the Canada Drug Agency, which is an agency that looks at the evidence and say, is it worth it? And then when the word worth, of course, is laden with, a lot of values, a lot of different connotations and so forth, and CDA and INES have their own way of looking at value, but essentially that's what they were looking at, is their value in accepting this treatment in Canada at a certain price point. They looked at it. Now, of course, the next step that we have to go through is the PCPA, the Pan-Canadian Pharmaceutical Alliance. Once that's done, a memorandum is created, and which outlines the price point of the gene therapy. Yet you still need the provincial public formularies to accept that memo. So sometimes that memo, if there's not enough patients in the province or territories, that memo gets just shoved in someone's desk drawer and be gone forever. So you need the provincial public formularies to accept it. And then beyond that, of course, is individual treatment centers, right? Like, will the individual treatment centers also accept it? Here you go. This is a snapshot from the Canada's Drug Agency, right? The one where it looks at value. And what they said is that, and I'm going to read this to you. The sponsor meaning the drug company that makes exa-cel, anticipates that these cost livings will partially offset the acquisition cost of exa-cel, valued at I can't even say this, man, 2.8 million, okay? Based on the sponsor's analysis, a price reduction of approximately 39%, okay, would be required for this, for exa-cel to be considered to be cost-effective, meaning that the Canada Drug Agency is asking the company to reduce the cost of the initial 2.8 million price tag by 39%. So I think this is where both an opportunity as well as job, as well as work is needed, right? We need to work together, all of us, right? Including the hematologist, the stem cell therapy specialist that's going to be administering the stem cell treatment, as well as all our patient groups in Canada, as well as Canadian Blood Services and Hema-Quebec, to work together to come with a common framework, right? And CTTC and CanHem has began this dialogue, and we will be expanding this dialogue to all the groups very, very soon. And we believe, both CTTC and CanHem believes, like all of us doctors believe, that equity and accessibility is key. We don't want someone from, say, Saskatchewan, okay, to not be able to access therapy just because they live in Saskatchewan, or that they live in an area in Quebec or Ontario or BC where there is no treatment center. And we feel that by working with all the groups here, that we will be able to accomplish this. But we need everybody's voice. I also believe that there is a way for us to leapfrog away from this. And that's technology that can potentially make gene therapy easier and more accessible. Most recently, at American Society of Hematology, there were 2 abstracts which I found to be very interesting. One is a way in which we can edit the gene correction in vivo, meaning that we do it in the person's body without the use of the chemotherapy agents, right? So you're going to skip the entire step with being in hospital. Same as this prime editing, by shielding your stem cells from an antibody-based conditioning regimen, which again could potentially be deployed outside of the hospital. And with this, I draw to a close and I will let Donnell take over again, Dr. Ivy take over again. Thank you very much.
Thank you so much for that presentation, Dr. Kuo. It was very informative. There was a lot of information. I do see that we are getting a lot of questions. And as I mentioned before, I want to hold off until we have all of the presentations. Some of the questions may have been answered, but I'll try to go through as many as I can at the end. But we're going to go through the presentations first. And so right now, I want to introduce Gabriel. And so just to read a little bit of Gabriel's bio. So Gabriel Badigio is a Toronto-based Afro-Canadian producer, director, and sickle cell anemia activist. From a very young age, Gabriel had a passion for storytelling and filmmaking. After graduating from the Toronto Film School, he landed a production assistant role on The Next Star and started climbing the production ladder. Gabriel has worked with major brands such as Google, Converse, Land Rover, and the award-nominated CBC Gem series, The 410. He has also worked with artists such as Billie Eilish, Jessie Reyez, and Popcan, to name a few. Currently, he is working on his first feature documentary and a Hot Docs Doc Accelerator Fellow. Pushing for change, Gabriel is an Ontario Health Sickle Cell CUSAC member, dedicated to creating better lives for people with sickle cell disease. Thank you so much, Gabriel, for giving of your time today, and I look forward to hearing your presentation.
Thank you, Dr. Ivy, and thank you, everyone, for having me. Hi, my name's Gabriel, and as Dr. Ivy said, I'm a filmmaker, but I also was born with sickle cell SS, and I had the fortunate opportunity of participating in a stem cell transplant trial back in 2021. So I did a bone marrow transplant, and so I guess I'm like 4 years post transplant now, and I'm feeling good and feeling great. So just to give you like a rundown of my experience and what led me to my decision making in part, doing this. So pretty much, I had a pretty bad crisis that kind of like laid me out for quite some time, and I wasn't used to being out that long. I was kind of used to, having a crisis, being in the hospital for like a week or two or whatever, and then, a little bit of time in recovery, and then I'm back on the streets doing my thing. But this crisis, I was like laid out for like 6 months, and it had a big impact on just, I just really felt my mortality, I guess. And uh, my doctor, after an appointment, just said that they were doing trials and asked if I would participate in it. And my initial reaction into a bone marrow transplant, because I've looked into it before, was that I wouldn't want to put anyone in my family through a bone marrow transplant, because before, when they would do a bone marrow transplant, they would like drill in the donor's bone and extract it, or in their leg or their back or whatever. And then they would have to, drill in your body. And then, it was a whole ordeal. And I just thought it was too invasive and too much to ask of somebody I care about. But he told me that, you know, they do bone marrow transplants a lot for like other illnesses, and the technology and the systems that they use to extract bone marrow and stem cells is a lot different now, and it's honestly pretty much like a blood transfusion. They give the donor an injection that they have to take for like about 5 days, and it causes the body to create more stem cells and releases it into the bloodstream. And they pretty much, you might know, but like maybe you've done like a blood exchange before, where they, you know, take out your sickle blood and they, give you fresh blood. So it's pretty much that process, but they're just extracting the stem cells and then they're putting back the donor's blood back into them. So it was like really less invasive. So once I knew that, like it kind of like changed my whole like thought process on it. And I asked my sisters if they would be down to get tested and to see if they're a match, and they were down, and one of my sisters was a match. Um, and pretty much for me, like going into it and making this decision, especially coming off of that big crisis, that major crisis that I mentioned earlier, was that like, you know, I didn't want to, just suffer more from sickle cell, really. Like, if as I was getting older, like I was experiencing more crisis more frequently and stuff, and like if I have more crisis like that, where I'm not able to work and do the things I want to do and stuff like that, um I think that would like do a big number on me mentally. And also like I'm kind of like a risky person, so my kind of like thought process was like, either I take the chance and if it doesn't work, it might be the wrap for me now, or I take the chance and it works and it's good, or I don't do it and I, just live with what I already know. And uh the other like big thing in terms of like my decision making was that like I just felt in myself that I was ready to make a big risk, um, take a big risk on this, like, just in case it doesn't work. Like, um, I'm satisfied, with my life and what I've, done and the connections I've made on this, on this earth while I've been here. So I was pretty satisfied with it. So either way, if it didn't work, cool. I did my thing while I could. And if it did work, amazing bonus. And that was kind of like my mentality going into it. So um, big things going into it is that you have to do chemo and radiation. Pretty much the chemo suppresses your immune system, so your body won't fight the cells that are coming in, and then the radiation knocks out your bone marrow, so you can grow new bone marrow. And with that, it, I guess, damages or it affects your fertility. So I had to uh bank my sperm. And I think I know I'm just learning actually recently, like, for women and freezing eggs and stuff, it's a much bigger process than it is for men. But yeah, I just wanted to mention that I did like, you know, freeze my sperm, just in case I want to have kids later. Um, and they do a ton of testing to like prep you and make sure that you're okay to, go through this process. They literally test everything. So you'll have like a ton of appointments, just doing all these checks. Like I was in and out the hospital, like for different scans and such, like pretty much several times a month. And the other big thing is that like they tell you it's a 2-year kind of recovery process, where they can know that you might be on the immunosuppressant drug, and they can kind of determine if graft versus host is like a thing for you or not, like Dr. Kuo was mentioning before. And so really, I just try to going into it like knowing that it's going to be a long process. Like I try to save as much money as I could. Um, and thankfully I was still living at home and I had the support of my family. But essentially I didn't work for like 2.5 uh sorry, that about, yeah, give or take 2 years at all. because there was like a lot of ups and downs. But anyways, going back to the chemo, once you do the chemo and the radiation, you pretty much start your transplant. And you might hear like how severe and chemo and radiation is, especially like, you know, hearing that from cancer patients and stuff that have been through that. But if you have sickle cell, the things we've been through and the pain we feel, like honestly, is just like not like nothing comparable to that. So for me, the symptoms and things I felt from doing the chemo and the pain I felt wasn't anywhere close to a sickle cell crisis. So it's kind of a cakewalk, but I can see for like other people that don't have sickle cell or a chronic illness like this, and they go through that and they're not used to that level of pain and discomfort and stuff like that, how it might be jarring for them. But for me, it was pretty easy. I did have a crisis after the radiation, like episode kind of like flared up, but because I was in the hospital and the staff were just really on it, like they addressed it right away, and the crisis like kind of cleared up like within a day, which was great. And then you know, after you do all that, you get the stem cells infused in you, and it's honestly kind of like anticlimactic because it's literally just, you know, cells that they had frozen in a bag, and they just infuse it into just like any blood transfusion. Um, but it was still like a, you know, a big emotional moment for me because, you know, it was like this thing that, you know, I've kind of like dreamed about happening, and just never thought it can happen is actually kind of a reality, whether it works or not, like, you know, something's actually happening. And you know, after the infusion, and it takes time for your body to take to kind of just reset. Your body pretty much has to reset and start from scratch. And it takes time. And within that time, I had a bit of, I wouldn't say a bit. I felt a lot of like symptoms, like pretty much they knock out your immune system. So everything gets you sick. Like if someone coughed around me, like a day later I was sick. Or if someone sneezed or whatever, or something was dirty or not clean or something, like I was getting sick all the time. On top of that, my it took a while for my hemoglobin to uh get to like a good level, and it dropped a lot. Like my baseline, you know, with sickle cell was maybe about like between 80 and 90, and my hemoglobin like frequently dropped to like 60 and 50 and stuff, where I needed a lot of blood transfusions and stuff like that. And you you know, throughout that like recovery process, there's just a lot of fatigue and tiredness. Like I was taking like multiple naps a day on top of like sleeping through the night, but also your sleep patterns like affect, or my sleep pattern was affected because of the um all the meds and stuff I was on or whatever. And so there was like a lot of you know, little things here and there that um like they weren't crisis sickle cell crisis level big, but they were big enough to like kind of like make me sit at home and need to rest. And it really, I didn't really start feeling good until like a year and uh a half after the transplant, where I actually felt my body like start getting stronger, and I wasn't getting sick so often and stuff. And um yeah, it was a kind of a weird kind of like experience, because like I kind of felt like a like kind of like a, I don't know, like my body, there was like a light switch in my body where it's like I was struggling, and then I wasn't struggling as much, and then from there things have been like really good. And I'd say like, you know, if you're considering, doing transplants, I think the biggest thing is one, just like really being comfortable with either outcome, because if it ends up not working out, like it could be a really devastating reality. So being comfortable with that, and then also, you know, and this is something I'm like realizing post transplant, but I didn't really feel it when I was in it. But us people that have sickle cell like experience a lot of trauma, and a ton of trauma, whether we're repressing it or not. And I highly recommend, if you're considering this or just in general, like doing therapy, which I did not do before, um, doing therapy before and, throughout this experience, because essentially your entire reality of life is going to change because, you know, we've been living with sickle cell our entire life from birth. So our identity, sickle cell is just as big a part of my identity as being Black, so um and when you go through something like this and it's like starting to work and stuff like that, all the things that kind of informed all your decisions and the basis of that has changed, and that mental gymnastics and journey is a tough journey. It's not like all like fun and rainbows. It's not like you get cured and you're like just dancing about and things are just great. There's still like a mental battle and things you have to get used to. And the other thing too is just like financially, like, you know, I had to save up a lot of money to, hold myself, and plus like the support of my family, which was big. And yeah, things got pretty hard because it's like, you know, you're doing this treatment and you need your body to be really healthy and you need to have all the right foods and stuff like that, to give your body the best, to be in the best position to heal properly, right? And it's hard to do that when you're broke and you're really on like a Mr. Noodle budget, but you need to be eating like, a lot of chicken and greens and all sorts of things, and stuff like that. So yeah, the financial aspect I think is like kind of a big thing and could be a stressor. So like, just if you're considering this, just making sure you have those like provisions in place. Yeah, so so far also I just wanted to mention in terms of like pain, um I don't feel like I barely feel like sickle cell pain anymore. Like sometimes I feel like a tiny bit, but like nothing past a 1 or 2. And I can feel sometimes when my body wants to act up, but it kind of feels like there's like a blocker, like kind of blocking it from happening. So, I've been pretty good ever since. And yeah, thank you for listening, and looking forward to any of the questions you guys have.
Thank you so much, Gabriel. And I do hope that we have time at the end to address. We are getting quite a few questions, but I hope we can get to as many as possible. But right now, we've heard from Dr. Kuo about uh, um, stem cell transplant, and bone marrow transplant versus the new gene therapy. We just heard from Gabriel about his personal experience with going through a transplant, to help with his sickle cell disease. But now, we're gonna hear from Lanray about where we are in the process in Canada for getting it approved and getting individuals with sickle cell disease access to this new therapy. So Lanray Tunje Ajaya is a global patient advocate for sickle cell disease with decades of experience in patient engagement and program development. She co-founded the Global Alliance of Sickle Cell Disease organizations, and the Global Action Network for Sickle Cell and Other Inherited Blood Disorders. As the co-founder of SCAGO and Sickle Cell Disease Association of Canada, she has significantly raised the visibility of sickle cell disease in Canada. Her efforts include advocating for newborn screening, securing funding, and influencing health policy. She is also recognized for her leadership with several prestigious awards. So thank you so much, Lanray, and please give us an update on where things stand with access to these therapies.
Thank you so much, Donnell. First of all, I wanted to thank Dr. Kevin Cole for your detailed and explanatory presentation. I also want to thank you, Gabriel, for your bravery and for sharing your journey with so many people today. I think you are an inspiration and you are my hero. Thank you, Gabriel. I wanted to, talk a little bit about where we are when it comes to CASGEVY in Canada. And I have a few slides. I know we have a lot of questions that are already in the chat box, so I won't take a lot of time because I think some of what I also wanted to share, Dr. Kevin Cole has also, gone ahead and spoke to most of those. So, so I want to really talk about advocating for, access to CASGEVY and similar therapies in Canada. Like Dr. Cole mentioned, we do not have a lot of, treatments for sickle cell disease in Canada. While honestly, to some degree, I'm very proud of Canada that we are very good in vetting, therapies, drugs very well before we approve it. I find some countries approve more rapidly. Let's take our time. Let's make sure that these therapies actually are very good and we won't have problems with them before we approve them. But at the same time, we need to have access to more, and which we currently do not. How do we gain access to therapies? It's through advocacy. And I wanted to say that advocacy is simply an act it could be by an individual, it could be by a group, by an organization, and their focus, their aim is to either support, promote a course, an idea, a policy change. They might want to drive a policy change. They might want to influence decisions within political, economic, social systems and institutions. But that advocacy work will be considered effective when the group or the individual achieve what they were targeting to achieve. And advocacy can take various forms, such as lobbying, public speaking, writing letters, organizing campaigns, and using social media. And all of these tactics and strategies is what we utilize at SCAGO. So let's talk about improving access to modifying and curative therapies. Like Dr. Cole said, modifying therapies like hydroxyurea, and even we also have blood transfusions, it's also modifying therapies. These are not cure, but there has to be better access to them. Not everybody, even here in Canada, that are good candidates for hydroxyurea, still has access to them. Many times patients are reaching out to us at SCAGO that they are not able to even buy their hydroxyurea because they don't have money for it. When you have to make a decision between food and your medication, many people will go for food. And with inflation and people losing their jobs and all of that, it's becoming increasingly difficult for people to have access to hydroxyurea. And we know that currently hydroxyurea is not indicated for sickle cell in Canada. And that has become a barrier to we as an organization in advocating for the government to cover the cost. Our goal is for hydroxyurea to be free for anyone that is a good candidate for hydroxyurea. But the first thing we have to do is to ensure that hydroxyurea is indicated for sickle cell in Canada. That is an uphill battle that we're still working on, as many of the companies that are making hydroxyurea, as you know, hydroxyurea is generic now mostly, and there is no money for the manufacturers to go and submit to Health Canada on this, but something that we're still working on, because hydroxyurea should be free for everyone that is eligible for this modifying therapy. Now, when it comes to curative therapy, Dr. Cole has spoken a lot about that. You have the bone marrow stem cell transplantation, but with that, you need a compatible donor. But then you look at the gene therapies. With that, you don't need a donor. It's your own, gene, your own cell that is modified and put back into your body. So we find that this therapy is, though it's an emerging therapy, people are really interested in it because, hey, I don't have to look for a donor, and two, the rate of success is very high for those who are good candidates for it, right? In terms of the gene therapy, the two that are out there that everybody is talking about is the Lyfgenia, which is made by a company called Bluebird Bio. The cost is estimated at about 3.1 million US dollars. And then CASGEVY that we're talking about today, which is the one that is approved in Canada. Lyfgenia has not been introduced to Canadian market, so we're not worried about Lyfgenia. We are talking about CASGEVY today that has been introduced to the Canadian market, and it's for both sickle cell and transfusion-dependent thalassemia. And it's for patients 12 years and older, and is made by a company called Vertex Pharmaceutical, CRISPR Therapeutics. That is estimated at about 2.2 million US dollars. So to get this drug, so there are processes, right? Regulatory approval process, because I think as a patient community, we need to understand clearly how this is all done. I know Dr. Kevin Cole has alluded to some of these steps, but I just want to also share with you. So the first thing is the sponsor or the manufacturer. We have to submit a market access authorization application to Health Canada. And that company, like I mentioned, is Vertex, right? And then this is where Health Canada would then review the submission, right, to ensure there is scientific evidence of the product safety, efficacy, and quality. They also have to make sure that the benefit really outweighs the risk of the therapy. And they also have to ensure that there will be unprecedented efficacy for people that will be using this therapy. And in this case for CASGEVY, the people with sickle cell disease SS and people with thalassemia, transfusion-dependent thalassemia. So which in essence is more like the more severe cases of these disorders, right? And for whom there are extremely or currently limited treatment options. So once that is done, then Health Canada will then issue, once Health Canada is satisfied, then Health Canada will then issue a notice of compliance and a drug identification number to the sponsor. Now, the NOC does not mean that the drug will be funded by the province. That's another advocacy that has to be done, another work that has to be done for that. But at least you get the Canadian market authorization. And then how do you then, once you get the Canadian Health Canada market access authorization, the job now begins. How do you submit in Canada to the public drug program to ensure that this treatment, is covered by the government for the people? So the first thing you have to do is you have to then submit as a sponsor, which is the manufacturer, have to submit to Canadian Drug Agency, which covers, federal, provincial, and territorial drug benefits plan, right? Except Quebec. In Quebec, you submit to INIS, which is the Institut National de Excellence en Santé et Services Sociaux, and you submit to them, and you're looking for them to review and provide recommendation for this treatment to be reimbursed by the public program, so that families don't have to look for 2 million, 3 million themselves for their loved one to go through this process, right? So once that is done and the submission is made to CDA and INES, CDA would then invite stakeholders' inputs. So who are the stakeholders that the CDA will typically invite? It will be patient organizations, and they are believing that the patient organizations are representing the voices of the patient. And they will also invite clinicians who will be treating the patient. They will also invite comments and feedback from drug programs from different provinces and territories to provide input into the reimbursement review for that particular therapy. Then INIS and CDA would then look at what has been submitted from the stakeholders and also find other relevant information that will be important for them to use in making a recommendation. They would consider all of this before a decision is made. In the case of CASGEVY, it was a positive decision that was made when they review all of the inputs from the stakeholders. And the Canadian Drug Expert Committee, CDEC, which is an expert committee under CDA, it uses the common drug review process to review CASGEVY and before recommendation was provided. And so the recommendations that the CDEC provided on CASGEVY was then shared with the sponsor. So that is where they will go first. They will go back to the manufacturer and say, this is the recommendation on your submission. And then they also share the same recommendation with the drug programs across the provinces between 8 to 10 business days after the expert committee has met and given them that recognition. At that stage, it is called draft recommendation. This is because CDA will still have to post this on their website for stakeholders' feedback. Do we agree with the recommendation? Do we not agree? We have to put our voice out there at that point again to ensure that if there's anything that we want changed or we're not happy with, can be, addressed, right? This is when stakeholders, including patient organizations, clinicians, and co, will then review the draft recommendation again and provide feedback again to CDA INIS. You have to use the same. It is after this second stage that then CDA and INIS will review, and then they will then provide their final recommendation on the reimbursement. And they will also post that final recommendation also on their website. Now, the sponsor or the manufacturer of this therapy, we also have to work with the Canadian Pharmaceutical Alliance, PCPA is what we call it. And PCPA engages with provincial, territorial, and federal government to negotiate cost of therapies, right? We want to make sure that Canada is not paying too much for these therapies. They will consider how much is it being charging Canada compared to other countries of the world. And they will then identify, okay, this is great, this is good, or no, they would say they will negotiate with the manufacturer to say bring the cost down and so on and so forth. So in terms of CASGEVY, I want to say we are not in the negotiation stage yet. However, I want to advise that PCPA has provided some sort of acknowledgement to Vertex, but the process of negotiation for CASGEVY has not begun. So in Canadian dollars, we were looking at CASGEVY will cost about 2.8, 2.9 million. Maybe when they do the negotiation, this can be brought down to ensure that more patients are able to access this therapy. As Dr. Kevin Cole said, there has to be equitable access to therapy. So if the cost comes down, it will ensure that more patients are able to benefit than if it's too high. And then when all of these processes are being done, it is at the end of the day in Ontario, for instance, it is the Executive Officer of Ontario Drug Program that will make the final decision on whether a drug is reimbursed in our province. So even though CDA, INIS provide recommendation, it does not mean that automatically it will be reimbursed by the province. This is province by province. So Ontario has to decide, Saskatchewan has to decide, every province has to decide. But in Ontario here, it is the Executive Officer of Ontario's Public Drug Plan that will make that final decision. And also, this is where patient organizations need to put their voice in there to ensure. Now, just a recap on this, I did a this flow charts right here to just help you understand that the manufacturer, like I mentioned, will submit to Health Canada, right? For authorization, they will also submit to the CDA and INIS, for instance, if it's outside of Ontario, for public drug funding, like if it's Quebec. Quebec is INIS, right? Health Canada then issue notice of compliance and DIN number, right? After they've reviewed and make sure this drug is safe, this is good quality, there's efficacy, scientific background. And then the CDA AMS, of course, review for clinical and economic evidence. And then they provide recommendations to public drug plans on whether or not to fund the product. And whatever it is, they also have to provide the criteria and the conditions that attach to their recommendation, right? And in Ontario, because this is our province here, all manufacturers that requested drug funding consideration must make a complete submission to the province, to Ontario, right? And also I want you to know that sometimes there are some drug products that might not be eligible for review through the CDA AMC reimbursement review process. There's also another committee called to evaluate drugs, CED. Those also reviews the clinical and economic evidence, and they can also provide recommendation to the executive officer for the Ontario Drug Program, whether or not to fund a product, and if so, what criteria on what condition. When all of this is satisfied, this is when it goes to the negotiation process, whereby with the PCPA, they negotiate with the manufacturer on what the cost should really be. And then it is the executive officer of the Ontario Drug Program that then makes the final decision. So what is the state of CASGEVY in Canada? So like I mentioned, submission to Health Canada was done in 2024. And then September, Health Canada provided market access authorization for the product. And then CDA also, all last year, recommended this drug for reimbursement. Currently, like I mentioned, the negotiation has not started, but PCPA has acknowledged to Vertex that they have received their application. And similarly, this sponsor, which is the manufacturer, is working at provincial levels to get CASGEVY put on provincial formularies. Okay, I want to stress here, because we have received a lot, and we continue to receive a lot of feedback from many families that they are not aware of this curative therapy, that their doctors are not discussing this with them. I want to encourage you that you can also initiate the discussion with your hematologist. If they are not mentioning it, you can say to them, I want to know if my child, if myself, if I qualify, and so on and so forth. Please initiate these discussions and learn more from them. As Dr. Cole also mentioned, people who have access to bone marrow transplantation are currently not eligible for CASGEVY, and people with SC, type of sickle cell disease, are also currently not considered. But what did we do as an advocacy advocacy organization to ensure that there is improved access to CASGEVY? Number one, once we learned that the sponsor has submitted to Health Canada, and that Health Canada has provided market authorization for CASGEVY in Canada, we sprung into action to submit our feedback on the reimbursement to CDA, and that we did that. And what we did is, before we made the submission, we surveyed the sickle cell community, because we're supposed to represent the voice of our patients. So we sent out a survey to the community to get their feedback on what do they think of CASGEVY. Is this something they would want? And these are the criteria and the conditions, and how do they feel about it? And we take their feedback, and that's what we put into our submission with CASGEVY to CDA. And with our sister organization, Thalassemia Foundation of Canada, along with the Global Action Network for Sickle Cell and other inherited blood disorders, There was also additional submission for thalassemia and for sickle cell from the GANSIT global level, also from Thalassemia Foundation of Canada, to support people, that have, that have both sickle cell and thalassemia. I want to stress that when you're doing advocacy, you have to get as many support as possible. It doesn't have to be just your organization alone. You bring other organizations that can also support and work with you to advance what you want to achieve. I also want to mention that one thing we did not agree on, that we have sent another letter to CDA, is the fact that people are being limited. For instance, when they're saying that people who may be, so when they're saying that CASGEVY will be for those that do not have access to BMT, there are many reasons why people might not want to go through BMT, even though I might have access to it, I might have a donor. Maybe for some reason that maybe I still do not think it's the best thing for me. Why then should I be limited and not have access to this therapy just because I might have a donor? And so we don't think that was fair, and we have sent another letter. I believe TFC and Sickle and GANSIT did that letter and sent to CDA to reconsider that condition or criteria. So on that note, I'm going to say thank you again for everyone that's been here. I think this is very interesting. I know we have lots of questions, and so we will move on to that aspect. And thank you again. Thank you.
Wonderful. Thank you so much, Lanre, for that presentation and giving us that explanation of where CASGEVY is and the importance of advocacy. I will ask now if Dr. Cole and Gabriel can turn on their camera, and we're going to try to go through as many questions as possible. Now, we do have quite a few questions. What we can do at SCAGO is, if we're not able to get to all of the questions, we can put a question and answer, a fact sheet on our site. So please check back at the SCAGO website if your question isn't answered today. I will ask the panelists as we go through these questions to be as succinct as possible so that we can get through as many questions as possible. But we do want to have a rich discussion here as well. So please make your responses very thoughtful. And so we start with one question: what are the indications for this therapy and the total cost?
So right now, per the public information on the Canada's drug agency listing, is 2.8 million was proposed by the company. The Canada Drug Agency has asked the drug company to lower the price by 39% in order to it to be acceptable. Now, this itself does not indicate that that's the final price. There's also needs to be a negotiation between the drug company with in the Pan-Canadian Pharmaceutical Alliance, the PCPA, which is composed of the all the provinces and territories health ministers.
Wonderful. And I will just add that, that's definitely the financial cost, but individuals also need to Gabriel's point earlier, consider the personal and non-financial costs. That includes time from work, time from other like activity. There is the cost also with the financial aspects of, hey, you might have to stay near the hospital if you have family members there. So definitely work with your social worker, work with your healthcare team, and then consider those other costs. I wanted to see if any of the other panelists wanted to add to the response.
Absolutely, Dr. Ivy, that is so important, right? And not just the patient's cost, also the caregiver, right? If you're a mother of, say, 3 child, right? What are you going to do while you're inpatient in the hospital for a month? Who's going to look after your kids, right? Like, you're lucky if you have your parents-in-law, but if you don't, right, who's going to do that child rearing for you? I mean, can your husband or wife stay home, right, for a month without work? Especially considering that many people on contracts, they don't necessarily have good health benefits or good financial coverage at the work. Not only that, we also have to consider the cost to the individual hospitals that are providing treatment as well, because it's not just the cost of the CASGEVY, but also the bone marrow transplant itself, right? The cost to stay in hospital. The average cost per day to stay in hospital, just being in hospital, is around $2,000 to $3,000, just being there. Let's not even count the cost of the nurses, the drug treatments, you know, the transfusions, etc.
Wonderful, thank you. I want to do a follow-up question. I'm going to skip around some. There was a question about private insurance and whether that's accepted, and will that be considered in the cost?
Private insurance is definitely accepted, right? So it depends from insurance to insurance. You need to check with your insurer as to whether there is. Usually with these sort of high cost therapies, it requires special authorization. So your doctors need to write like letters and advocate for you, essentially, your team. The other thing with these is that please always double check your insurance, because some insurance have what we call lifetime maximum. And sometimes these lifetime maximums are very, very small. I mean, when I say it's $1 million sounds a lot, but when it's $1 million for your entire family, it's very little. Because we have to remember that these plans are often, even though it says Sun Life, it's not Sun Life that's actually providing the coverage for you. It's not, Sun Life is not, like, for example, I'm just giving Sun Life as an example. The insurance company is just the administrator of a private plan. And often with small businesses, that's the only way in which they can provide any sort of healthcare benefits to you.
Thank you.
Those
Thank
are
you so
very
much for that response. Lanray?
Oh yes, I just wanted to add, like, like it's been said, it's not just the financial cost that we have to look at. We have to look at the cost of the family, your work and all of that, and then weigh everything to see, is this really for me, or not? So yeah, a lot of things has to be taken into consideration, cost of babysitting and all of those things, even for parents with children with sickle cell also. Thank you.
Wonderful. I'm going to move on to the next question. So it says, can people with SC, and I think this one was answered. So right now, SC disease is not considered as a covered condition with this disorder. There is a question about, if you have a splenectomy, is this an issue as there's chemotherapy as part of this treatment?
Yeah, I can take that question, Dr. Ivy. It is not. Unfortunately, the risk of infection is universal once your immune system is completely wiped out, regardless of whether you have a spleen or not.
Yeah.
So everybody is susceptible. Yeah.
Yeah, and my understanding though, Dr. Ko, is that the renal function, though, your kidney level of kidney disease would be considered, since the busulfan that you mentioned earlier, that's cleared by the kidneys. That's your body gets rid of the busulfan by the kidneys. So the level of kidney function is a consideration.
Oh, absolutely. Absolutely.
And so then we have, just following up on that, so it's asking, so CASGEVY, is it only for individuals or people that are between 12 and 35?
That's a very good question. In the clinical trial, initially it was limited to that range, and then later on it was expanded. We have to keep in mind that in terms of the product monograph, like what is approved is 12 and above. Having said that, it is likely that the first few patients that will be treated in Canada would be limited to that age range. Simply because many people with sickle cell disease who are, as they get older, accumulate or begin to develop more and more complications, and that could make the treatment journey much more difficult.
Yes, definitely. Our next question is, if a patient has a bone marrow donor, he's not eligible for genetic therapy, the gene therapy, but is he eligible for a transplant? And so why would a person that has a bone marrow donor not be considered for gene therapy?
Yeah. So assuming that your donor is what we call compatible, right? Like fully compatible, both from blood group as well as from an HLA perspective, we have such excellent results and such long history. I mean, the treatment with bone marrow transplant or stem cell transplant in people with sickle cell disease using a matched sibling donor stretches all the way back to 1984. So we have had more than 30 years, 40 years of experience using this. And because you get such great results from it, it's almost like a no-brainer in terms of why you shouldn't pick it.
Okay, wonderful. And I believe, Gabriel, you did see in the chat that someone did want to connect with you. So that was a question. I do have a question. I'm going to skip around some here. And it says that a mother to a son who is a sickle cell patient, and he's 23. If his siblings to a warrior is a half match, is there a chance that they can still be a donor?
Yeah, so that's an excellent question, actually. So that's called haploidentical transplant. Haplo means half. And we as in like all Canadian centers as well as the US centers are sort of actively looking into making it a good approach right now, because traditionally it's actually quite dangerous to do that. But now with the better technology, we're actually able to do this much better and better. It's not prime time yet in Canada, I would say, because there's still a lot of risk, and the procedure is much more complicated than, say, doing the matched sibling donor transplant. But we're working on it, and we're hopefully, like for example, in Toronto, we hopefully will within the next year or so, we'll start our first haploidentical transplant.
Okay, wonderful. Wonderful. We do have a question here. Oh, I'm sorry, Landray, did you? No. We do have a question here. If you can speak about the exclusion list more and elaborate on how patients can advocate to seek treatment for those exclusions so that they can be considered. So we do recognize that there is a long list of exclusion criteria that you mentioned, but how can patients go about advocating for, getting more of those exclusions removed?
The exclusions are not there to limit people from accessing it. They're there to protect the people, meaning that those who are excluded will have conditions that makes it too dangerous for them to go through a transplant. As doctors, our first code is not to kill, right? Not to do harm. So those are there not to exclude people for the sake of excluding people, but they're to make sure that we don't cause unnecessarily harm to people who, in a therapy that we still don't know long-term wise, that's going to provide benefit.
If I can add to that too, um, you know, everyone that does the treatment, like so far, all the folks that have done it in Ontario at UHN, I've kind of connected with, and we kind of like, chat about our experiences. And all of us have had different symptoms in different degrees at different times. And like we've all had pretty unique experiences, doing the same procedure. And like, yeah, like, some of these exclusions and stuff, like, when they say that when Dr. Quo says that, they're there more of as a protection for us, like they really are, because some of the symptoms and how you can be affected by these things are kind of, in a way, like not like fully predictable yet. And yeah, it's just something to be cautious of, like, just if just because like there's a possibility doesn't mean it's like the right thing, because again, like it's still a risk.
And you're so right, Gabriel, if I may chime in, because I think there are risks to this thing, right? We all want a cure, but not, fortunately, not everybody will be eligible. And again, because there are risks that actually could be dangerous for some people if they go through these processes. But I'm also very happy to learn that you have more like a peer group or, connection with those who have gone through BMT. I think that's a very good and that's very powerful. That there's that such connection with folks who have been there and who maybe others can also, reach out to you to learn more about your experiences and so on. That's great.
Yeah, and I'll just add, if I may, about some of those exclusion criteria as well. One of them is that if you are successfully treated with other therapies such as hydroxyurea, then that would probably be a benefit to continue on that hydroxyurea. I personally have been on hydroxyurea for 30 years, since 1995, and it's worked wonderful for me. And as Dr. Kevin Cole said in his presentation, what the new gene therapy does is kind of mimic what hydroxyurea is doing. So if you can be effectively treated on hydroxyurea, you'll probably be considered for that first. I will also say that as bone marrow transplant that Gabriel went through has been done since the 1984. I think was the earliest bone marrow transplant, not specifically for sickle cell disease, but in a sickle cell patient. And since that time, we've recognized that doing bone marrow transplants with sibling donors is very effective. So I would imagine that the healthcare system wants to look for those strategies that have been researched and done over the years before moving to the new gene therapies, particularly when you consider the cost of the therapy. Okay, I know we have several more questions. I'm gonna try to continue here. There is a question about, so after the BCL11 CRISPR-Cas knockout, are the stem cells sequenced before they are returned to the patient?
So if the stem cells first go through a growth phase where you need to make more of them, because even though we collect a lot, it's still not enough, and then some will die along the way as we manufacture them. And then once the BCL11A is knocked out by the gene therapy, the cells will then need to go through a quality check before they are frozen and returned back to the patient.
We do have a question about if we could comment on if previous damage from sickle cell disease. So if someone's had damage to end organs, the liver, the brain, before they have this therapy, if that's reversed by the bone marrow transplant or by CASGEVY.
Yeah, unfortunately not. Once the damage occurs in our body, the damage is permanent. And that's what's so devastating about sickle cell disease.
Yeah, if I can add to that, so for me, some, I guess, like permanent damage, like my kidneys were, sickle cell has done a number on my kidneys. I developed avascular necrosis in my hips. And I'm still affected by those things now. Like my kidneys are in worse shape than it was before. And I still feel, pain in my hip due to the avascular necrosis. So it's like, all those things that you're dealing with before outside of the sickle cell pain that's already happened, you're still going to be dealing with. It's just that they might not get worse or as worse, like, quickly or whatever, because the sickle cell's not there doing, more damage, but whatever is done is kind of done already.
And then there's a question. Oh, I'm sorry, Landray, where did you have?
No.
Okay. There's a question here about are there other gene therapies approved or in the process of approval? And they have here Zentelgo. And then are we going to see more companies with similar gene therapies seeking approval in the next 1 to 5 years?
It's $1 million question. And the reason I say it's $1 million because it costs an average for the company just to submit an application. Let's not even account for like the cost of doing the clinical trials, like gathering up all the information and so forth. $606,000. More than $500,000 just to submit an application, just to put those paper together and hand those paper to Health Canada. So I think it's unlikely because because of the landscape. It's you have to consider, right? I mean, in terms of number of people in Canada, there's only what 6,000 people with sickle cell in Canada. So it's difficult for a company to justify spending almost $500,000.
Yeah,
So
and I will add to that some. I mean, so I do still work with or groups in the U.S. and there are pharmaceutical companies still looking for different approaches and different strategies. There, as Dr. Cole mentioned, though, there are financial challenges to those companies continuing to do the research. So I will say, I am hopeful that there are quite a few that are in the pipeline, I would say, but some of those companies are having challenges with continuing to do the research, can get given the large cost of doing this.
Dr. Ivy, I think the ones that may have a hope are 5 to 10 years down the pipeline, and these are the in vivo ones, right? Because once we can do gene therapy without having do it in the hospital, that'll just open up doors. And without using chemotherapy, that'll open up doors.
But Dr. Cole, if I may ask you, what do you think of Lyfgenia coming to Canada? He's currently approved in the US, but do you think he will come to Canada as well?
Well, first of all, Lyfgenia just went bust. They went bankrupt. A private company bought it, so now it's private. It's no longer public. Before they closed, they were penny stocks. Second of all, is they've had a number of blood cancer related to their products. There were 2 in sickle cell, but then there were 8 in another disease called amyotrophic lateral, ALD. I need to remember. It's a brain disease. I don't exactly remember the exact name, but the acronym is ALD. There were 8 cases of it in like 60 or so patients treated.
And thank you for that. The reason I asked is that I know a lot of our families are circulating. There was one person that was treated in the US recently with Lyfgenia, and a lot of our families are circulating that and asking more questions about it. So I'm happy that you clarify that we might not see. And I think we always know the risk with Lyfgenia is way more than with CASGEVY from what we've seen from clinical trials. So I think we should be happy with CASGEVY here. And hopefully there'll be more new ones in the pipeline. Hopefully, fingers crossed. Thank you.
And if I can add about the cost of things and how much it costs to submit an application and whatever, and what we can do as a community is we really need to come together and have a unified voice and not be scared to talk about it and advocate for ourselves, to put pressure on these pharmaceutical companies and government agencies and stuff like that to push for a decision that works in the favor of us. We really need to be shameless with advocating for support.
Agreed, Gabriel. And this is why we're encouraging patient community to work with, your patient organizations, right? And come together as one voice, working working to push forward with governments and in getting, because you will get what you want if your advocacy is persistent and if you do it right, right? But individuals cannot be going to the government one by one. You have to go with a focus and as a group and, let them know what it is that you want. This is what, like I said, before we even submit to CDA, we did a survey to get the feedback and the voice of the patient in that submission. And that's how we have to continue to drive this, working together. Thank you, Gabriel. Well said.
And I just want to add, the research, as Dr. Cole said, is continuing with in vivo studies, but there are also non-curative sickle cell treatments that are in the pipeline as well. And as a person that has benefited from hydroxyurea, I also want, I try to be optimistic and hopeful. And I do think there are some very promising therapies that are non-curative that are in the pipeline as well. And I don't know if you want to speak to that, Dr. Cole.
Sure, yeah, but So there's a number of other therapies right now that includes increasing the amount of energy inside the red blood cells so as to make them healthier and less chance of sickling. So that's called, that group of agents are called pyruvate kinase activators. There's also a number of companies that are looking at using drug method to increase the fetal hemoglobin other than hydroxyurea. And there's a number of agents out there right now that are undergoing clinical trials. So I would sort of do a quick plug about clinical trials, is that it's a great way of accessing these cutting edge therapies that are at a no cost to you. Plus, also you get more care as a result of it. You'll be seen more often. You'll go through. Maybe some of you can speak about the experiences here on the panel as well.
Yeah, and I'll say, like, I was on the trial for hydroxyurea. That's how I started, even before it was approved by the FDA. As I said, so the doctor that I was working with at the time, approached me about, hey, would I be on the clinical trial for hydroxyurea? I was hesitant. But then after evaluating all of it, I said, yes, it's important to do these clinical trials, to participate, because that's how we make progress. So I will encourage everyone to learn more about clinical trials. And yes, it's not going to be right for everyone. There'll be people that they can't overcome the, hey, I don't want to be on a clinical trial. But I would encourage you to learn more about it and then put it as a consideration.
And just in line with that, there's a question there that says, how do we learn about clinical trials? So you can ask your doctor questions about clinical trials. Sickle, for instance, also has current trials in Ontario. On its website, you can check there as well to know what is there. What are the clinical trials in sickle cell disease as well? But bottom line is, I think having that discussion with your doctor also is very important. For some people, being part of clinical trials has resulted in cure for them, not just in sickle cell, but even in other disease areas. So we should be part of clinical trials, because without clinical trials, there can be no cure. So there can be no way out. So we need to be part of clinical trials. Thank you. I think we have 2 minutes, but we still have a few more questions. There's one from Timmy that I think we need to take that question for sure.
Which one, can you read it?
Yes, so Tim is asking Dr. Coles directly. He said, I'm a sickle cell disease SC patient with chronic pain and frequent hospitalization. And I heard you talk about the first half match BMT in UHN. Is there a way for me and my brother to be a part of that?
So Timmy, along with you and all the members of the audience here, I encourage you to talk to your doctor, your sickle cell doctor, about the treatment options, because everybody, as we said before, is individualized. I mean, I've shown you sort of the general roadmap of how people get access to the therapy and the qualifications, but of course, if it was that easy, then we don't need 6 months to a year, right, to figure out who is eligible and who is not. So talk to your doctor.
Thank you. And there's another question here, if I may help you, Danielle. Whereby somebody was asking if they will have to pay for the treatment out of pocket. So no, this is where currently we're talking about the PCPA, whereby the sponsor or the manufacturer is trying to work with the provincial drug plan and the Pan-Canadian Pharmacy Alliance to ensure that the treatment is covered so that you don't pay out of pocket. But like we said earlier, there are other expenses. Like you have to think about if you're going to stop working, if you're going to need a babysitter while you're doing if you have a child, need a babysitter while you're going for your treatment, and all of those that OEP is not going to cover for you. Government is not going to cover those for you. So you have to think about those additional costs, but the cost of getting that treatment itself hopefully will be covered, by the Ontario Drug Program.
Wonderful. And we are at time. I know we're at 1 o'clock. I wanted to just quickly share just with everyone that SCAGEVY does have upcoming events. We want you to be able to participate in everything that SCAGEVY is doing. And so on June the 14th, please mark your calendar. at the Renaissance by the creek, located in South Creek Road, we are having our Hope Gala and Awards ceremony. So if you go to the SCAGO website, you will be able to find more information about our Hope Gala and Awards banquet. So we ask that you will please consider to mark your calendars for that. In addition, we do have the dates confirmed for our annual SCAGO Sickle Cell Summit. That will be on August the 15th and the 16th. It will be in the Greater Toronto area. Our theme for this year is shaping a healthier sickle cell community tomorrow through actions today. And as we learned, we're not going to make progress if we don't take those actions and those steps to make sure that progress happens. So we have to figure out how to work as a community. And that's beyond the medical, as we heard. That's also the legislative, that's also the community, to figure out how we can improve sickle cell disease care. So please mark your calendar for the Sickle Cell Summit on August the 15th and the 16th. With that, I would like to thank our participants today for participating in that. I know that we probably didn't get to all of the questions, so what we will do is try to take down the questions. We will reach out to Dr. Quo, to Gabriel, and to Lanray to have those the answers to those questions posted on the SCAGO website. But with that being said, I know we're past time. I want to thank everyone for participating in this Learning for Life session today, and I look forward to continuing to work with everyone to improve sickle cell disease care in Canada.
Thank you, Dr. Ivy. Thank you, everyone. Thank you.
Thank you for inviting me. Bye-bye.
Thank you, everyone.